Thank you.
Thank you so much, Stacey. I appreciate it. Good evening, everyone. I'm happy to be here. So for today, we'll be gathering a bit of a better understanding in terms of the relationship between sleep and pain, including the importance of sleep and pain management, a bit about sleep physiology, what research tells us, and how we can work toward improving both from a biopsychosocial approach toward management. And we're going to be walking away with some actionable strategies, resources, and a take-home message at the end. So a little bit about setting sort of the stage about the importance of sleep in chronic pain management. There have been decades of research dedicated toward understanding how sleep impacts pain. And it turns out there's actually what we call a bidirectional relationship between the two. For instance, sleep loss, which equates to sleep deprivation to some degree, results in lowered pain thresholds, thereby increasing our pain sensitivity, while extending sleep can increase pain threshold, providing this natural pain relief. We also see that sleep loss is associated with increased inflammatory markers in the body, which are also linked to pain. So regulating sleep can help regulate these markers, potentially reducing our levels for pain. During deep sleep stages, we see that the body undergoes processes of restoration and healing that we'll be discussing in a bit, including muscle repair and growth hormone release. These processes are crucial for managing chronic pain and facilitating recovery. Chronic pain and sleep disturbances can contribute to mental health issues as well, like anxiety, depression, which in turn can further disturb sleep and pain management. And addressing these, particularly addressing sleep quality, can have a positive effect on mental health and pain perception. Chronic pain and sleep disorders significantly contribute to lost productivity and healthcare costs. And again, in talking about how important sleep management can be for pain management, we see that improving sleep can help mitigate these economic impacts by reducing pain severity, improving overall health, and therefore quality of life. Patients with chronic pain who report better sleep quality tend to also respond better to pain management treatments. Sleep improvements can enhance the efficacy of both pharmacological and non-pharmacological pain treatments. And according to the American Sleep Association, about 50 to 70 million US adults have a sleep disorder, with insomnia being the most common. Again, we'll talk a little bit more about various sleep disorders in just a moment. Chronic pain affects approximately 20% of people worldwide, showcasing this global significance of understanding and addressing the sleep-pain connection. I apologize for all of our audience. I am fighting a cold, so if you see me pausing to take a drink of water, thank you in advance for your understanding. So let's dive a little bit deeper into understanding sleep. And to orient us, I want to highlight some common sleep disorders that may be relevant to chronic pain management. This is not an exhaustive list, just to showcase some common ones that interfere or interact with pain, the most common one being insomnia. It is defined as difficulty falling asleep, staying asleep, or having early morning awakenings for more than half the week for a period of time lasting 3 months or longer. We also have sleep disordered breathing, the most common of which is obstructive sleep apnea, which results in partial or total obstruction of the airway during sleep, resulting in poor quality sleep, and it is associated with numerous health factors. This is what we would call a medical condition that really impacts other health markers. Other common sleep disorders that interact with pain include circadian rhythm disorders such as shift work or delayed sleep phase, or we call non-24 sleep phase, restless leg syndrome, parasomnia such as nightmares, and hypersomnia, the tendency to oversleep, perhaps, as a general explanation. I won't go into much detail about the specifics of each of these, but provide an overview of how they might interact with pain and pain management. So to help us dive a little bit deeper into understanding sleep, let's talk a little bit about the sleep architecture. In healthy adults, this is what we might see as a typical representation of a night of sleep. To orient us to the graph a little bit, we have at the bottom of the graph on the x-axis, total number of hours of sleep ranging from 0 to 7. And on the y-axis, we have highlighted the various stages of sleep. We have wakefulness up at top, not a part of sleep, but it is a part of sleep. In fact, sleep is a 24-hour process. Not just something that happens at night. And then we have REM, which stands for rapid eye movement. This is where a good majority of dreaming happens, although dreaming tends to happen in all stages of sleep. This is really the one that's associated with the bulk of it. And it is also often associated with memory consolidation and emotion regulation, whereas we've got 4 non-REM stages of sleep. The first 2 are considered very light stages of sleep. We're more likely to wake up from these stages. And then we've got stages 3 and 4, which are commonly bulked together as N3, because even on a polysomnography, it's actually quite hard for us to detect the difference between stage 3 and 4. And this is where a good majority of restoration is associated with. And we tend to get the bulk of our deep sleep, which are these stages 3 and 4, at the beginning of the night. So it doesn't matter what time of the night we fall asleep, we will get a majority of our deep sleep during that time. And if we take a look at the graph, it might be, let's say, about a couple hours or so, right? And even though the sleep stages go in a cyclical ultradian cycle, I should say, that average about 90 minutes, that first cycle tends to last about 120 minutes to really, showcase how we're getting that big bulk of our deep sleep earlier in the night. And if we notice, wakefulness tends to happen, like I said, in lighter stages of sleep. So it's more likely to happen in the second part of the night. Not necessarily second half. That second part can start about a third of the way in. And that means as adults, because we're spending a good majority of our time in lighter stages of sleep, therefore we're also more likely to wake up and perhaps stay awake for some time. So general rule of thumb that we might give folks is about 20 to 30 minutes to fall asleep is considered fairly normal for adults. And about a half hour of wakefulness in the night is also considered normal. And we might not remember a good majority of the times that we wake up in the night because they're too brief, but it doesn't necessarily make them out. When we recall awakenings, they tend to be about 3 minutes or longer. That's when we are more likely to remember, oh yeah, I was awake and for some time in the middle of the night last night. So let's move on to understanding another big aspect of sleep, which we call the 3 systems that either help or hinder our sleep. The first one we're going to talk about is the sleep drive. This is our hunger for sleep, our pressure for sleep. When we wake up in the mornings, generally speaking, if all things have gone well, we don't have this massive hunger for sleep. It's not like we're going to go back to bed and go to sleep for another 7 to 9 hours or so, right? So we're fairly satiated. That's at the bottom of the graph, right over here, in case you're able to see my cursor. So we work through the day to build up this pressure for sleep or hunger for sleep, all the way so that come bedtime, whatever that might be, we've built up enough of it to help us go to sleep and stay asleep. The more we are able to build up this sleep pressure, you're probably looking at adenosine and wondering why that's there. I'll talk about it in just a moment. The more likely we are to be able to fall asleep and stay asleep throughout the night in order for us to wake up in the morning and do it all over again the next day. With respect to adenosine, in case for folks are familiar with ATP, adenosine triphosphate, which is our source of energy in our body, when we burn energy as we go throughout the day, we are breaking these individual ATP bonds, adenosine, and the 3-phosphate bonds that are on it. And that's how we get those bursts of energy, little tiny bursts that make up a greater amount of energy. And so throughout the days, we're burning up more energy. We're building up all this loose adenosine in our body that contributes to that sense of feeling sleepy. So building up that sleep pressure for us. The more of that loose adenosine we have, the more we are able to be sleepy throughout the day. This, as you might imagine, is really important, especially if we're going to be talking about sleep and the importance of making sure that we are moving our body, we're engaging in things that tire us out, whether it's physically or socially or mentally, so that we're able to feel sleepy throughout the day by the time sleep time comes. And again, go through that process of going to sleep, staying asleep. Hence why we say sleep is a 24-hour process, not just something that happens at night. And so the second system that is important for us to talk about is the circadian clock. We have every cell in our body has a circadian clock, but the one that I'm talking about is our sleep-wake circadian clock that is housed in the suprachiasmatic nucleus in our brain. This is essentially controlled by our receptors in our eyes, in the back of our retinas, that are highly sensitive to blue light or broad spectrum daylight, blue light coming from broad spectrum daylight. And that signal, when we get plenty of it, gets sent to our brain that essentially tells our brain it's time to inhibit melatonin production. It's time for me to be awake and function throughout the day. And so in the evenings, when the sun is set, it probably wouldn't be very realistic for me to expect anybody to turn off all sources of light. But we do say that it's important to protect about an hour, ideally 2 hours, but even an hour will do, to limit the amount of light that we're exposed to, including bright ceiling lights, the ones that are pointing at me right now, or our screens, in order to stop that signal being sent to our brain saying that we need to be awake. That way, we're actually promoting melatonin production that can support us feeling sleepy and prepare for bedtime. The third system that is important to highlight is our autonomic nervous system, which is essentially broken up into 2 equal halves. When one goes up, the other has to, by nature, go down, and vice versa. We've got our parasympathetic nervous system that is essentially associated with that rest and digest, versus our sympathetic nervous system associated with that fight or flight response. We need both of these throughout the day to some degree. We're in that sympathetic response. Whether it's to a high degree or to a low degree, we're active, we're going throughout the day, we're awake, we're tackling tasks. And come nighttime, I think you'd all agree that sleep and stress cannot happen at the same time. And so that's when we really want to highlight and be able to kick in our parasympathetic response in order to bring down that activation, that arousal, so that we're able to put ourselves in a state of rest and digest to be able to go to sleep. And that's going to be really important, especially in part when talking about pain management and the comorbidity of sleep and pain disturbances. So stay tuned. Another big aspect of understanding how sleep works is really to understand that sleep is a biological process, but specifically one that we can override with our behaviors oftentimes, or medication. So just taking a look at that big list of images that we have on slides, we can see anything from caffeine, alcohol, medications, whether it's sleeping pills or medications that can be wake promoting. We can override our sleep system, this very biological process. Things like shift work can be another one, or traveling across time zones, holding an irregular sleep schedule for whatever reason, meaning frequent bedtime and rise time changes. Napping during the day can be another one that can override that sleep system in a way where we're not building up enough sleep drive after that nap in order to actually have our main meal, which is at bedtime. Substance use, the other piece that I want to talk about here is nicotine, for instance, which is a stimulant, and it can cause a high degree of difficulty falling asleep as well as sleep disturbance, as it, again, like I said, it's wake promoting in the sense that when we're experiencing that withdrawal, it's waking us up. We got to get our next kick. Some environmental factors to keep in mind include light exposure, probably similar to what I had shared earlier with exposing ourselves to bright light, especially that blue light coming off of screens, which can inhibit that melatonin production and making it harder to fall asleep. Noise can be another one, loud or sudden noises that disrupt sleep, especially for folks who might be more sensitive or lighter sleepers. Temperature regulation can be another big one. Extreme temperatures don't have to be too extreme in order for us to notice them and for them to interfere with our sleep. General rule of thumb that I might give folks is we tend to sleep better in cooler temperatures, but what might be cooler temperature for me versus someone who might be in a tropical landscape versus someone coming from Alaska might be very different things. So to some degree, it is subjective in that sense. And certainly when it's too cold, it can also be difficult to get comfortable. That might be another factor maybe to consider. Use of technology is another big one. Electronic devices, I feel like I kind of hit on that a little bit in terms of our the light, but the other piece is what we engage with as well. It's not just the light that comes from our screen, but it's also the content. It might be very different if we're watching a rerun of our favorite brain candy show that is very lighthearted versus the news, which can be very anxiety invoking to some degree, or a horror movie. So it's also important to consider what we're engaging with, not just how much or when. There's also sleep tracking and apps that folks tend to use for sleep tracking. So anything from wearable devices to tracking one's sleep. And the piece that I want to share here is, again, sleep is a biological process. And we don't want to do anything to necessarily override it. And that includes monitoring it so closely that we're now treating sleep like a performance rather than the biological process that it is. So it's important to qualify why we're using certain tracking. If it's a short period of time during a course of CBTI, which is cognitive behavioral therapy for insomnia, or if we're just really curious and now we're tracking it. And research shows that when we start to monitor our sleep so closely, even good sleepers tend to develop sleep problems. So that's something that is important for us to keep in mind. Now let's dive a little bit into beginning parts of research for this interaction between sleep and pain. We've already begun to see how emerging research underscores the profound impact of sleep on chronic pain management. Understanding this relationship is crucial for developing more effective treatment strategies for managing both, really. So the first thing to take note of is that sleep loss is not the same thing as insomnia. And a lot of the research that I'll be talking about, or that you're likely to read in terms of sleep and the impact on pain, often highlights sleep loss, which essentially is, like I said, depriving of sleep. So, pardon me. What I mean by this is insomnia is often, we've got plenty of opportunity for sleep. Let's say I'm in bed for 10 hours, but only sleeping for about 5 of those hours. lacking some details here, but generally that might be understood as a little bit more reflective of insomnia, whereas sleep loss might be I'm only in bed for 5 hours, and even though I can sleep a good majority of it, but it's far too short for my body, my brain might need. And that might be because of either things like shift work or having a newborn baby and needing to get up, or having medical conditions like obstructive sleep apnea that results in wakefulness throughout the night, or alternative things that are waking us up, like pain, for instance. So stay tuned for that as well. And what we notice is research highlights that nearly 89% of patients with chronic pain have reported disturbed sleep patterns. These studies are establishing this clear correlation between sleep disturbances and increased pain, disability, depression, and reduced daily functioning. This bidirectional nature of this relationship suggests that improving sleep can significantly enhance pain management outcomes. And not limited to pain management, sleep work tends to be a gateway to improve various other aspects of our well-being. It tends to be the case that when we see improvements in our sleep, we see improvements in levels of anxiety and depression, this sense of gaining some functioning throughout the day, in addition, like I said, to pain reduction as well. We also see that there's research showcasing how extending bedtime for those who are mildly sleepy, perhaps alluding to being sleep deprived, increases sleep opportunity, meaning that they actually get a little bit more total sleep. And this results in not only a reduction in their sleepiness, but actually a reduction in their pain sensitivity. So there's this big correlation between sleep loss and pain sensitivity. And the American Sleep Association also showcases that sleep disorders like obstructive sleep apnea and restless leg syndrome have been shown to co-occur with chronic pain conditions. Again, just really highlighting that interlinked pathophysiology and the need for integrating treatment approaches. So I guess the piece to highlight here is that there's a compelling body of evidence suggesting it's important for us to be addressing these two pieces that could actually be pivotal in chronic pain management as a whole. And to a great degree, even the Stanford Pain and Sleep Clinic have joined forces to address this very issue that we'll highlight later as well. So to talk a little bit about that bidirectional relationship, sleep disturbance equals higher pain levels equals poor sleep, and that can be a vicious cycle in itself. And we also see that there is what are called consequences of chronic sleep pain interaction that are important to highlight. Comorbidities, we already highlighted to some degree, social aspects that we're going to be highlighting a little bit more later, but this impact of relationships or impact on, on relationships, whether it's engaging with our loved ones or our coworkers or upper management level, and negative impact on intimacy and sexual activities is another big one. We highlighted briefly that quality of life, whether it's psychomotor functioning or difficulty to perform daily activities, and certainly that socioeconomic piece. And this is perhaps just kind of bundling them all together to provide a visual representation of what we're talking about. We've got some recent research insights that are quite fascinating to consider. I don't present myself as an expert in these areas. I'm just one who is fascinated by anything on the biological level. And I think it's important for us to just be cognizant and mindful of some of these pieces. And more research seems to constantly be coming out of these parts. So a recent review article showcases the mechanisms underpinning sleep and pain interaction. They highlight that sleep deprivation affects the body's ability to modulate pain, with studies showcasing specifically that altered pain facilitation and inhibition mechanisms end up changing or being impacted in a negative way after sleep disturbances. There's inflammation that highlights sleep losses associated with increased levels of those pro-inflammatory cytokines, suggesting that link between sleep deprivation, inflammation, heightened pain sensitivity. I feel like I'm a little bit of a broken record. Hopefully I'm not boring anybody by this point. Affect, mood, psychological states, endogenous substances. This one is a little bit newer for us as we're talking about this. The role of dopamine, orexin, melatonin, and vitamin D in modulating sleep and pain are explored in a great degree by a lot of these studies, including this review. And I was distracted for just a moment, pardon me. They highlight that their contribution to the complex interplay between both sleep and pain conditions is calling for more research to be done so that we have a better understanding, and maybe again building that the bio part of that biopsychosocial interaction when we're talking about treatment. There's also anatomical brain areas that are highlighted. This article points to specific brain regions such as the nucleus accumbens and the anterior pardon me, anterior mid-cingulate cortex, which may be involved in the modulation of pain by sleep disturbances, as well as the cyclic alternating pattern, which is a marker of that sleep stability, and discussing the potential impact on pain sensitivity. So lots in the works as far as future directions for building a better understanding of the impact of sleep on pain and perhaps vice versa. So let's take advantage of learning a bit more about the biopsychosocial model. I think the name kind of gives it away. We've got biological factors, psychological factors, and social factors that really interplay. And it's important for us to sort of integrate these pieces, these factors, to develop a deeper understanding of what brings about issues at hand and how we're able to manage and make things better, for lack of a better word. So with respect to pain, for instance, this comprehensive approach recognizes that pain is not merely a physical sensation, but it is influenced by emotional, physiological, and societal factors. So some examples of biological factors here include things like pain intensity, physical health, trauma, injury, disturbed sleep. Pain is a big part of it as well. Medication use, inflammation, disease severity, brain function, activity level. I won't go into detail for reading all of these, but again, just highlighting all the various factors that we would be assessing for from a clinical perspective to develop a better understanding of what is bringing about and perhaps holding our pain levels or that chronic pain diagnosis or the symptoms in place. Likewise, for psychological factors, everything from pain perception to coping skills, fear avoidance, mood and stress are big aspects that, again, are important to assess, understand, and develop plans around. There might be things that we can change. There might be things that we cannot change. And it is still just the same important to develop an understanding of what's in the picture in order to provide a more holistic approach, or at the very least, build some skills around being able to sit with and continue to walk toward what we want in life, even though there might not be an immediate change that we might be able to bring to one aspect. But we still have to live our lives, and we can still choose how we want to do that, what is meaningful for us. Social factors, these are going to be essentially the same between sleep and pain, I think. social support and our environment, our ability or disability to engage with work, or even our daily activities, economic factors, environmental factors. So similarly, it's important for us to understand what might be in the picture when it comes to sleep disturbances, what's bringing about and holding our sleep troubles in place. Again, there's biological factors that are at play, which are a little bit different, I think, in terms of what I might consider as a sleep psychologist. Age, the older we get, the more likely we have, for instance, to have some wakefulness in the middle of the night that we may not ever be able to get rid of, per se. Not all of it. We can support it, just because by nature, as we're getting older, we're spending more time awake, and because of the fact that we're spending more time in lighter stages of sleep. Gender is another piece. For instance, not to bore you with too many of these pieces, but female identified individuals, or I should be saying female sex individuals, are more likely to develop insomnia, whereas male individuals are more likely to develop sleep apnea, although there's a lot that says sleep apnea is diagnosed and supported in female individuals, especially post-menopause. So there's, again, biological factors, psychological factors, our beliefs about sleep. If we're holding onto, if we're so married to some of these ideas about what sleep is and how it impacts our lives, we're less likely to build that psychological flexibility to be open to realizing, actually, to some degree, that's not accurate. I'll give you guys an example. Often we'll hear something like, I absolutely require 8 hours of sleep to sleep and to function the next day. That's not necessarily accurate. I'm sure you'd agree that there are times where all of us have gone with probably far less than 8 hours of sleep, and we have continued to function that day. We still showed up to our lives and to our work, and it might not have been the best day of our lives, but we functioned. And it's not so helpful for us to hold on to these ideas so tightly. And likewise, social factors that I've highlighted the same ones here again for sleep as in pain. So diving a little bit deeply into what management might look like given these pieces. From this biopsychosocial approach, what biological management might look like. Things like medication management might be one. For instance, there's physical aspects of pain that can be supported to some degree with medication, and it is important to combine medication with behavioral strategies for a more effective approach. And it'll always be important for us to speak with our medical providers, with prescribing providers when it comes to medication management, especially ones who are more familiar with our case and our history. Again, perhaps from this biopsychosocial approach, to be able to better support us in making decisions when it comes to medication management or tapering, for instance. Lab workups, again, this sort of falls on our medical counterparts to help understand what our blood work makeup is telling us, what story that's telling us in terms of what we need in our bodies and how we can best support treatment. Medical conditions, coordination of care is a big piece from a psychologist perspective. I often will be working with our medical providers when working with patients, because I think it's really important to make sure that we're developing a deeper understanding of what that whole holistic care and in what areas we're able to support one another in order to support our patients in a more cohesive manner. And the more we understand exactly what folks are going through, the more I'm able to understand what folks are going through on these various levels, the better I'm able to make even smaller recommendations. So for instance, if again, I'm maybe drawing a little bit on my own experience as a sleep psychologist, when working with a patient who might be coming in with POTS, who is reporting tachycardia and is having a hard time engaging in a lot of physical activities, that's going to shape the way that I'm going to be making some recommendations with that sleep drive that we talked about earlier. So as an example. Certainly physical therapy is another big one. Any adjunctive and augmentative therapies like acupuncture are going to be incredibly important to consider at the very least. I think having our options and not using them is better than not having the options and needing them. And certainly sleep medicine interventions is also a big part. For instance, PAP therapy for sleep apnea. Even though I'm a sleep psychologist, and you'd be surprised there's a lot to be done with PAP therapy, especially when it comes to PAP desensitization. If you're having a hard time falling asleep, but you're asked to wear this mask that feels really uncomfortable, that's an issue, and that's an issue that I might be able to support with. Or chronobiotics for circadian rhythm disorders. That includes things like light therapy or microdose melatonin. And I realize I'm probably throwing out some words that might seem larger than the time that we have to cover them. But again, these are interventions that can be augmenting that overall therapeutic approach. Some psychological factors or interventions to consider would be, for instance, cognitive behavioral therapy for insomnia or for pain, behavioral interventions, everything from perhaps falling in on my own expertise, things like sleep education. Some of the pieces that I shared earlier actually are things I will go through in detail with folks, because I think it's so important for us to build an understanding and a deep education around the thing that we're trying to work toward. And I tell folks that I want them to walk away feeling like they deserve a degree in sleep, whether it's sleep medicine or behavioral sleep medicine, jokingly. Time-based activity pacing is another really great behavioral intervention that is utilized by our pain clinic and folks who are doing some really wonderful behavioral interventions for managing chronic pain, where we're really bringing down this, not anticipation isn't the word I'm wanting to use, expectation, ultimate result for what we want to do physically. And we're really minimizing that expectation of ourselves and our body by saying, gosh, if you're noticing that it takes, by the time you do 10 minutes of this activity and you're in pain, we're actually going to cut that down to about 5 minutes. And you're not going to be doing more than 5 minutes. We're going to be bookending that activity with movements that will sort of lotion up those joints and create an opportunity for your body to be able to rest and recuperate. And we're going to do that for some time before even going up to 6 minutes, and then do that for some time before going up to 7 minutes. I don't mean to sound as an expert in sleep management as my wonderful colleagues. Relaxation sort of covers both sleep and pain management, and it's actually something that I'm hoping to have some time to engage with folks toward the end of our visit. Mindfulness-based stress reduction is a great emerging therapeutic approach. Mindfulness can help patients sort of detach from that the pain sensations and reduce the stress that comes with it. And it's incredibly effective in improving both pain and sleep outcomes. Again, going back to what I said earlier in terms of there might not be some aspect of our pain that we can change, but certainly we can hold a mindful approach toward what that means and still walking toward what is meaningful for us in our lives. for those things that we're perhaps not able to change. Some social components for treatment include tackling social support. It is important for us to build and maintain social connections, especially when it comes to coping with chronic pain, engaging our environment, the people who make up our social support in treatment, whether it's inviting them to pain management visits, or asking them to join a class with us, or reading some of the materials that providers might be sharing, is one really big step toward building up that little community for us, so that we have more than just our own voice advocating for what is happening for us. Communication skills training is another great aspect. This is often offered, part of cognitive behavioral therapy, that teaches really effective ways to communicate pain experiences and our needs, not just to our healthcare providers, but also our family members, improving, again, that understanding and support. Patient advocacy and support groups, connecting folks with social workers or designated patient advocacy workers, and certainly considering vocational rehabilitation, everything from job placement services, vocational counseling, workplace accommodations, skills training and education, on-the-job training, assistive technology, all case management, things that we can consider in terms of how to ease the social impact or factor that might be contributing to our pain problems or pain experiences, and also sleep. So as far as some actionable strategies, establishing a routine is going to be a really big one. When we think about our circadian clock that we had talked about earlier, it's really important for us to build a routine that works for us and use and have a couple of things as sort of anchors. For example, when we take our medication around the same time every day, that is one form of an anchor that creates a routine or schedule for us. Making sure that we're waking up at the same time every day is another great anchor for us to ensure that, well, we're probably going to be able to go to sleep around the same time as well, if we're ensuring that we start our day at the same time, building up enough sleep drive, and we're not giving our circadian clock a moving target. Creating a sleep conductive environment is incredibly important. Everything from making sure that we actually have a comfortable mattress and a comfortable pillow, cotton sheets, some flow of air if it's too hot, whether it's a fan or having the AC on, or making sure that we have cooling blankets, or even those cooling mats and devices that sort of allow for increased comfort when it comes to temperature regulation. Minding our diet is another really important one. I wish we had all the time in the world to deep dive into this area. This is a big passion, growing passion area for me in terms of regulating our sleep-wake circadian clock with our feeding-fasting circadian clock. And recognizing that, for example, for shift workers, especially those who have alternating schedules, when we're not able to align our sleep by, our light exposure, to say the least, but also then it impacts our timing for our meals. It can be incredibly challenging for our gut health. And managing our stress levels. It's incredibly powerful if we kind of dive a little bit deeper into thinking how these various aspects of our health interfere with one another or interact with one another. Considering PT, gentle exercises, maybe I won't go repeat myself in some of these areas, certainly considering medications. Limiting naps is one that I say cautiously. For folks who are experiencing daytime sleepiness, with profound daytime sleepiness, I would actually say it's important to consider strategic napping rather than limiting them altogether. This might mean if possible, to limit naps to about 20 to 30 minutes. About 7 to 9 hours before bedtime would be a great small enough snack size so that we're able to build up enough hunger for sleep by the time our main meal comes around, which is come bedtime for that big portion. And that way we're increasing an opportunity for some sleep catching, some Z's that we've already established tends to support our pain thresholds and receptivity toward pain. So it's actually really important to be mindful of the way that we're engaging with naps and how meaningful they can be for us. The other piece that I really want to highlight is diaphragmatic breathing as one example of relaxation. And in terms of sort of building a case for diaphragmatic breathing as a really great supporter of relaxation, I always tell folks there's really two biological ways that an exercise like diaphragmatic breathing is going to help us go into that rest and digest relaxation mode. So the diaphragm is this dome-shaped muscle that separates our thoracic or chest cavity from our belly or abdominal cavity. When we exhale and are in that relaxed state, our diaphragm is in that dome shape and it is relaxed. When we inhale, lack of a better word, but essentially fill up our lungs, we bring forward our belly and we engage the diaphragm and sort of help flatten it out a little bit to make room, and the belly comes forward. When we do this if enough times, what we're doing is, on the one hand, we're moving our belly cavity, our intestinal cavity, and the structures that are in there. And we have 12 cranial nerves. The longest one is called the vagus nerve. And this is wrapped around our intestinal cavity. When we stimulate our intestinal cavity with this movement, we actually literally send a signal to our brain saying that it's time for us to be in rest and digest. Similarly, when we do this diaphragmatic breathing, we're slowing down the rate of our breathing. We're regulating it, right? And that means per minute, we're slowing down the rate of oxygen being deposited into our bloodstream and therefore our muscles. And I want you to think about oxygen as food for the muscle. So when we get less of it, we turn off our muscles, saying it's time for me to be in rest and digest. So these are hopefully two great ways to help convince folks as to why it's really important for us to be able to engage in something as easy and free as diaphragmatic breathing to help us in increasing our sense of relaxation. I was hoping to have enough time to walk folks through an exercise, but perhaps we'll skip, and I'm hoping that you're able to find this. It's free. We're able to find it on YouTube everywhere. And so a take-home message that I want to share is, one, we sort of highlighted sleep loss is not the same thing as insomnia, and it's really important for us to distinguish between the two. We've certainly highlighted the critical link between sleep and pain, especially in considering the impact sleep treatment can have on pain, and certainly vice versa. A lot of times, anytime in the sleep clinic that I was a part of during fellowship, for instance, our sleep medicine clinic, we saw folks who are already connected with the pain management team. Their sleep outcomes were often the improvements, the gains that they were able to receive in sleep management also improved. And they build upon one another. So it's really important to be able to manage both, especially if they're both in the picture. And hopefully I've sold you on the value of behavioral interventions improving outcomes. Some sleep resources I want to share with you. One I highlighted earlier, which is our very own Stanford teams. There's a wonderful 6-session class that is designed by our sleep clinic provider, Dr. Fiona Barwick, our lead provider, and our pain clinic provider, Dr. Heather Popor King, and it's called All About Sleep and Pain, ASAP for short, and it really showcases the value of treating both of these together, and you can see if there's quite a lot of overlap that's going to be supportive. I have my own private practice highlighted here. There's plenty in our wonderful Bay Area. I specialize in behavioral sleep services, and I wanted to showcase that in case anyone is interested. We also have some wonderful apps like the Insomnia Coach app that happens to be free. It offers self-guided 5-week training plans that are designed to change sleep habits. It is offered by the VA for free, and it can be it seems to continuously improve, which is really wonderful. We also have Stanford's very own Dr. Andrew Huberman, who has put out a Huberman Lab podcast, and he talks a lot about sleep. I believe he also has quite a bit on pain that folks might find interesting. Some books on sleep are here for whoever that might be interested. Some that I like to highlight are Improve Your Sleep. We have How to Sleep, The Sleep Solution, Good Night Mind, and Quiet Your Mind and Get to Sleep. The Improve Your Sleep workbook is also put out by the VA, and it is free. Even if you were to just Google search it, you would be able to find the link for the PDF for that workbook. And we have some wonderful resources put together by our pain clinic. And this is perhaps where I will ask our wonderful, let's see.